it was relapsed in 2016 after 8 years. At that time, the infusion route has changed. This is the standardized injection route were introduced in the hospital. So in every ward, in every ICU, even in emergency room, with a standardized infusion route system. And also, we have introduced during the eight-year period, introduced a new automatic blood culture device. According to the change of the device, the blood culture bottle, the shape of the blood culture bottle has changed. This is a newly introduced sure plug system, AD system. And this one is a new Becton Dickinson biometric of automatic blood culture device. So the bottle shape of the bottle is changed. The neck and inlet of the bottle is very small, so it is more difficult than the previous one to push into the needle from the top into the bottle to put the blood into the bottle. Let's talk about the sure plug system. Sure plug AD system has a dual access split system. See here. So no need to dedicate the dedicated connector. We can push into the syringe, or also we can use a lock type syringe. And Sure plug has this kind of system, not to no drug and no blood residue are stuck, cannot stuck in this part of the stop port. To compare the conventional type, when we pull out the syringe, some air or some blood can go in to this area, but after we removed the syringe, we don't have any residue of the blood or drug can happen with this sure plug AD system. Okay, over these changes happen in the entire hospital. So first, we have to look at the blood culture positivity rate in the whole hospital. From 2012 to 2015, the number of the specimen for the blood culture is increasing. And in 2015, the positivity rate, positive cases are increased first. And introduction of the new system is here. So where in the whole hospital, a system is changing, and the blood positivity rate are increased. But the breakdown, overall trend of the detected bacterial species are not so changed. pretty similar from 2012 to 2016. But when we look at the pediatric world, the blood culture positive cases almost doubled, and the increase is introduced by the detection of the coagulase negative streptococcus. I mean, this one is a contamination from the staff or staff hands or the patient and surroundings environment. Okay, let's go site visit again. And the root, line system is changed, but the root itself is too long, and the hub is on the floor again. And hubs are usually placed close to the patient's body on the bed and easily contaminate from the environment. And the new hub can be directly connected to the syringe, so it has a surface pushing structure. So the contamination of the surface of the hub are easily pushed into the in the line and through the line into the patient blood vessel. And for the kids, it is difficult to, collect the blood from the vein. So the root is used for blood collection. And also the patient has patients given the anti-cancer drugs. So the blood transfusion is frequently used through the IV route, and the IV route is not changed even after 24 hours after the blood transfusion. So the problem is many problems are found. And staff said that some blood left in the hub after blood collection. But the structure of the sure plug AD system cannot leave such kind of blood things in the hub structure. Okay, this time we have some experiment. We did some experiment. Here is a sure plug hub, and this is a line. So we applied a fluorescent ointment on the surface of the hub, and then connect the syringe and push the fluid into the line. So without any disinfection, without any scrubbing out of the ointment from the surface, the contamination of the fluorescent ointment are pushed into the line. But after scrubbing, after disinfection, after removing the ointment enough satisfactory by scrubbing the surface of the hub, say that there is a little bit residue of the ointment here, but almost no injection from the hub into the root. So the scrubbing out of the ointment contamination from the hub surface is important. Counts 867 and scrub the hub for 10 seconds and wipe off immediately after that this kind of disinfection, but still high count there. But after drying, the count will reduce. So the proper disinfection, and after that, contact time is essential for the disinfection of the hub. So this time, after injection of the hub, scrub the surface of the hub with alcohol cotton for 10 seconds, and change the alcohol cotton and wipe it again and allow it to dry. This is a best practice, part of the best practice for the disinfection of the surface of the hub. And use a syringe with a lock, and for the prevention of the contamination. And after collecting blood, or after using the line for the blood transfusion, prevent blood from accumulating at the connecting by pulsing flash. The fluid can push by pulsing flash for preventing here. Yeah, after something colored appear left inside the hub after blood collection, so we add this pulsing flash element after collecting blood or after blood transfusion. During the September, we intervened the pediatric ward and educate the more than 2 sets are necessary for the blood culture, but usually in the pediatric ward, the compliance rate for the more than 2 sets is very low. But after educating, the more than 2 sets, the percentage of more than 2 sets are increased, and positive cases are going down. And especially during the 2015, lots of CNS detection happened, but after intervention, there are no detection of the CNS from the positive blood culture. Importance of hub management are reported since the 1980s. They say the bacterial entry from the hub has been thought to be the cause of the catheter sepsis. And one report said the formation of the biofilm formation rate and colonization rate increased as the duration of catheterization is longer. I mean, from less than 10 days and more than 30 days, the biofilm formation rate increased, and also the colonization of the catheter, colonization rate of the catheter itself is increased. And surprisingly, contamination, when compared the internal inside the catheter and outside the catheter, intraluminal surface and external surface, biofilm formation rate And also the colonization rate is more seen in intraluminal surface of the catheter. So most bacteria is coming from the inside intraluminal entry from maybe from the hub. So we have to manage appropriately. I mean, to disinfect the surface of the hub. So using the 70% ethanol or the say in Japan 1% chlorhexidine in 70% ethanol preparation. Maybe in your country you can use more than 2% of chlorhexidine alcohol preparation for the infection for the disinfection of the surface of the hub. And how much time, how much duration we have to scrub the surface. Okay, 5 seconds is enough, or 15 seconds is okay. But one report said more than 10 seconds of scrubbing of disinfection reduce the surface of the surface contamination of the hub. So we choose the 10 seconds of this scrubbing disinfection of the hub. So for the appropriate management of the hub, we have to scrub the hub. Okay, lastly, I mentioned the approach for the zero CLABSI. First, the bundle approach. As you know, that lots of things, a guideline says that lots of effective measures for the prevention of CLABSI, but we have to select important elements because we cannot comply all of the evidence-based measures. This is a very famous study conducted in lots of ICU in Michigan. They select the 5 evidence-based measures. One is hand hygiene before insertion and maximal barrier precautions at insertion. Avoid insertion at femoral vein. This case is ICU. So when they use a femoral vein insertion, they have to change the insertion site from the femoral vein to the jugular or subclavian site after patient stabilization. And the skin disinfection with chlorhexidine, more than 2%, and remove unnecessary catheter. They have to check if this catheter is necessary or not every day. For this kind of evidence-based bundle approach, the CLABSI rate are gradually decreasing. So in all ICUs, okay. So during the long period, so they're getting lower and lower. Lower and lower. And another report showed that the post-insertion maintenance bundles consists of 6 elements. One is a daily inspection of insertion site and change dressing if wet, soiled, or not change for 7 days. Only once a week change, and daily assessment of catheter need, if the catheter is necessary or not. If the catheter is not needed, that kind of catheter should be removed. And proper use chlorhexidine impregnated sponges, and hygiene before handling the IV set. Before handling the IV set means before infusion or before change the route or such kind of timings. And also the bundles contain the scrub the infusion hub with alcohol for 15 seconds. With these maintenance bundles consisting of 6 different elements, the CLABSI rate is significantly reduced from 5.7 to 1.1 per 1,000 catheter days. But it is not enough, not with 0 CLABSI. But in some hospitals, 0 CLABSI already achieved. Toward 0 CLABSI, I'd like to introduce one hospital approach. One day they did a brainstorming for the prevention of the CLABSI. They pick up all the causes for the risk of the CLABSI, say the caregiver-related factors, patient-related factors, system and supply, and equipment. As you know, these are fishbone diagram. So they try to eliminate the risk of these kind of risk by introducing the several bundles. At first, the CLABSI rate at the hospital is quite high, but the introduction of the different kind of bundles, they reach to the 0 CLABSI. First, they try to educate the staff, the healthcare workers, fostering the culture for everyone's responsibility for reducing CLABSI, and introduction of the insertion bundle, including maximal barrier precaution, and the CBC maintenance bundles for proper management of infusion line. And also, in addition to that, as the last step, they introduce a housekeeping cleanliness bundles. So they try to keep the environment surrounding the patient clean. So with these bundles together, they achieve the goal of 0 CLABSI. This is one example, but not only the insertion or maintenance bundle, but also the environmental cleanliness bundle is necessary, I guess, for the accomplishment of the zero CLSA-BSI. This is the last slide, take-home message. The main causes of CLA-BSI are microorganisms entering through the insertion site and from inside the catheter. This means pushing into the contamination of the microorganism into the line. So the proper disinfection of needless connector hubs is important for preventing CLS-BSI. Scrubbing the hub is essential for preventing CLA-BSI. And it is essential to apply the evidence-based measures as a bundle, aiming for zero CLS-BSI by applying multimodal bundles is necessary. And thank you very much for your attention. This is the end of my talk. Thank you so much.
Professor Yagi, thank you very much for your insightful lecture. We will now proceed the Q&A session. If you have any questions, please write down in the Q&A box. We will introduce your questions from Q&A box and ask Professor Yagi answer to those questions. And please do understand, due to the time constraint, we may not be able to answer all the questions. So now let's proceed the first questions. Okay, so the first question is, what do you think are the differences in the causes of increase in positive blood cases between 2008 and 2016? And in both cases, would the main factor be the easily contaminated HAB environment and staff education on infection control boundary, including HAB disinfection? This is the first questions.
Okay. Yeah. Both cases, 2008 and 2016, the causative microorganisms is completely different. In 2008, mainly the glucose non-fermenting bacteria. It is a resident in the aqueous environment. The other time, 2016, the most causative agent is coagulase negative staphylococci. So it's directly from the skin or the environment contaminated with skin residents of the patients or the healthcare workers or parents together with living together with patients. Okay, and the situation is quite similar. The catheter hub is very high risk situation for the contamination, even from the aqueous environment while patient takes showers or the patients living in the wards hubs are very easy to contaminate from the surrounding environment. So when we develop the bundles for the prevention at those cases, the disinfection of the heart probably introduced from the heart during the injection of the medication or for the disinfection. Disinfection the heart surface is essential for both cases. We try to educate the staff, doctors and nurses also. At first together, both doctors, nurses, in the same occasion, because we have to look at the same direction for the prevention of the CLABSI. So at first, we educate. We have the opportunity to give them the educations at the same time. But after that, we repeatedly the chance to educate them, but at that time separately, using the best practice for disinfection of the surface of the hand. That.
Thank you very much for the answer.
Okay.
We got another one. We got a comment, and well, okay, when we introduce the comment, I understand that it is important to bundle several measures to prevent CLABSI. And okay, so this is the question. And what would be a good starting point for the hospital-wide infection control initiative with the aim of achieving 0 CLABSI? So the question is, what would be the good starting point? Yeah.
Good starting point. Well, in 2008, we have several different kinds of infusion line sets using in, say, for example, emergency room, ICU, and the pediatric department. In that case, it is very difficult to achieve the 0 CLABSI in the whole hospital, because the infusion line is different in each department wards sections, so that we have to educate differently for the prevention of the CLABSI in each department ward section. But after 2015, we introduced, our hospital introduced a standardized infusion system, even in emergency room, ICU, and pediatric department. So we can do this. We can do the similar same education for the prevention, standardized education for the prevention of the CLABSI. That we can share the same bundles for the prevention for the central line associated bloodstream infections. So that's a quite different situation compared to the 2008 case and 2016 case. But so that if we if we want to achieve the 0 CLABSI, first we have to start the introduction of a standardized infusion line system throughout the hospital. That's one point. That's a good starting point. But the first starting point is that maybe some infection rate is going up in one ward or in one department, so we have to intervene to such one department or ward. And when we develop the evidence-based bundles for the prevention of the CLABSI at one department, we can spread out the bundles throughout the hospital. So if the infection rate of CLABSI is high in your hospital, that's a chance to introduce some bundles in your own way in your hospital. So that's one good starting point, I guess. Also.
Thank you, well, we have got more questions. And the next question is, according to CDC guideline, we need to change the line after blood transfusion. So is that applied for Shropag AD as well?
Well, we're not actually in a hospital, but Shropag AD has a structure removing the blood from the hub portion, blood avoid system. So so we in addition to that, we are using the pulsing flash after the blood transfusion. So, for example, in a pediatric ward, patients had a long time. Patients have to insert the central line for a long time, and this is a tunnel, subtunnels central line, so it's not easy to replace the another site. So we have to keep it as long as possible. So pulsing flash method is one of the tricks for preventing the blood residue inside the line and prevent CLABSI, I guess.
Prevention of CLABSI. And do you have comparable study that shows the advantage of the flat surface head over the concave surface head in CLABSI prevention?
Yeah, flat surface is better, I guess, because if there is a bump, on the surface of the hub, it is difficult to wipe out the contamination completely. If the structure of the surface of the hub is flat, it's easy to remove. If the surface is, even though the surface is contaminated. So the flat surface, close to flat surface is very, important point of the structure of the hub. One of the important point.
Thank you very much, Professor Yagi. Well, we are about time, so we'd like to conclude today's webinar here, and here we'd like to say thank you very much for your valuable lecture today, and to all the participants, thank you very much for your attendance today. So lastly, we would like to inform that we are going to send a questionnaire after the webinar, and we really appreciate your cooperation on giving your feedback of today's webinar. So again, thank you very much for your time and the participation today. So we are looking forward to your participation in the next webinar.